Hello everyone, this is Dr. Moore, and this lecture will take a look at diagnosing disruptive, impulse control, and conduct disorders. We'll look at three diagnoses. First, oppositional defiant disorder, a childhood disorder characterized by negativistic, argumentative, and hostile behavior patterns. Then we'll look at intermittent explosive disorder, a condition involving frequent lower intensity outbursts or low frequency, high intensity outbursts of extreme verbal or physical aggression. Then we'll look at conduct disorder, a persistent pattern of behavior that violates the rights of others, including aggression, serious rule violations, and illegal behavior. The most common types of disruptive behavior disorders include oppositional defiant disorder, ODD, and conduct disorder. The main difference between these two disorders is the severity of the symptoms. Conduct disorder is often considered the more serious of the two. Disruptive and antisocial behavior in youth is the longest and most heavily studied syndrome in child and adolescent mental disorders, as externalizing behaviors are often alarming and are easily noticed by caretakers. These disorders are the most frequent referral problem for youth, accounting for 1/3 to half of all cases seen in mental health clinics. This reflects the recognition that adult sociopathy is almost always preceded by disruptive behavior in childhood. Oppositional defiant disorder is characterized by a persistent pattern of angry, argumentative, or vindictive behavior that continues for at least 6 months. These behaviors are directed toward parents, teachers, and others in authority. At least 4 symptoms involving short-tempered, resentful, blaming, spiteful, or hostile behaviors must be present. Adults sometimes begin to do whatever they can to avoid conflict, often without success. Although youth with ODD often argue, defy adult requests, and blame others, they do not demonstrate pervasive antisocial behavior or extreme verbal or physical aggression directed toward people, animals, or property. ODD is considered mild if symptoms occur only in one setting, and severe if the behaviors occur in 3 or more settings. Although the symptoms of ODD often resolve, especially with intervention, ODD is associated with interpersonal difficulties in early adulthood. Additionally, some cases of ODD begin to demonstrate the more serious rule violations associated with conduct disorder. ODD appears to have 2 components, one involving negative affect and emotional dysregulation, for example, being angry and having an irritable mood, and the other involves defiant and oppositional behavior. Negative affect predicts future depressive symptoms, where oppositional behaviors are more predictive of delinquency and conduct disorder. Additionally, approximately half of those with ODD also display inattention and hyperactivity. Let's proceed to look at the criteria for ODD from the DSM-5. A is a pattern of irritable or angry mood, argumentative, defiant behavior, or vindictiveness lasting for 6 months, as evidenced by at least 4 symptoms from any of the following categories. And I'm going to blow these up for us. And the DSM-5 is very descriptive in this diagnostic category. The first area is angry, irritable mood. 1, often loses temper. 2 is often easily annoyed. 3 is often angry and resentful. The next category is argumentative defiant behavior, which includes the descriptors number 4, often argues with authority figures or for children with adults. 5, often actively defies or refuses to comply. 6, often deliberately annoys others. 7, often blames others for his or her mistakes or misbehavior. And the final area is vindictiveness, which includes number 8, has been spiteful or vindictive at least twice in the past 6 months. Moving on to criteria B and C. B is the disturbance in behavior is associated with distress in the individual or others in his or her immediate social context, or it impacts negatively on important areas of functioning. And finally, C, the behaviors do not occur during the course of a psychotic, substance use, depressive, or bipolar disorder. As with all diagnostic considerations, we need to consider ruling out a differential diagnosis. Two of the most common co-occurring disorders with ODD are ADHD and conduct disorder. There is an increased risk for later problems in adulthood, such as antisocial behavior, substance abuse, anxiety, and depression. ODD has been associated with higher risk of suicide attempts, so it is important for the clinician to assess suicidal risk. It's more prevalent in families where there is a succession of different caregivers or where inconsistent, harsh, or neglectful parenting occurs. And the first symptoms usually appear during the preschool years and increase in frequency through adolescence. The next diagnosis we're studying is intermittent explosive disorder, which is a prevalent, persistent, and seriously impairing disorder that is both underdiagnosed and undertreated. A diagnosis involves A, recurrent outbursts of extreme verbal or physical aggression that occur approximately twice weekly for at least 3 months. These are high frequency, lower intensity aggressive outbursts. Or B, 3 outbursts occurring within a 1-year period that involve damage or injury to people, animals, or property. These are low frequency, high intensity outbursts. These outbursts occur suddenly in response to minor provocation, and this is important, they do not involve premeditation. Instead, they are exaggerated, angry, or impulsive reactions that cause distress or impair interpersonal functioning. Now, unlike the negative mood associated with disruptive mood dysregulation disorder, the child's mood is normal between outbursts. A child must be at least 6 years old, an age when children are presumed to have learned to control their aggressive impulses in order to receive this diagnosis. Not surprisingly, this diagnosis is associated with early exposure to familial aggression, violence, and interpersonal trauma. You can see the clinical description that I just provided spelled out in the DSM criteria for the diagnosis of intermittent explosive disorder. Criterion A, recurrent behavioral outbursts due to a failure to control aggressive impulses manifested by either of the following. A1, verbal aggression such as temper tantrums or tirades, or physical aggression towards property, animals, or individuals occurring weekly for 3 months. Physical aggression does not result in damage or destruction of property and does not result in physical injury to animals or people. Criterion A2, 3 behavioral outbursts involving damage or destruction of property and or physical assault involving physical injury to people or animals within a 12-month period. The remaining diagnostic criteria are as follows. B, the magnitude of the aggression is grossly out of proportion to the provocation or precipitating stressor. C, the recurrent outbursts are not premeditated and are not to achieve a tangible objective. D, the recurrent aggressive outbursts cause marked or significant distress in the individual or impairment in functioning, or are associated with financial or legal consequences. E, the chronological age is at least 6 years. And F, the symptoms are not better accounted for by another mental disorder. Let's move on to take a look at conduct disorder, which is characterized by a persistent pattern of antisocial behavior that reflects dysfunction within the individual rather than a pattern of behavior accepted within a person's subculture. And it includes serious violations of rules and social norms and disregard for the rights of others. It has been referred to by some clinicians as baby antisocial personality disorder because some subsequently go on to receive this diagnosis of antisocial personality disorder. Diagnosis of conduct disorder requires the presence of at least 3 different behaviors involving deliberate aggression, such as bullying, physical fights, the use of weapons, cruelty to people or animals, aggressive theft, forced sexual contact. Another category of behavior is the destruction of property, which includes fire setting. Theft or deceit is another category of behavior that can be characteristic of this diagnosis, and this involves stealing, forgery, home or car invasion, and conning others. And finally, behaviors may include the serious violation of rules, such as staying out at night, truancy, and running away. Deliberate rule violations sometimes begin in early childhood and then continue into the school years. In many cases, disorderly behavior increases or becomes more serious with age. Boys with conduct disorder are often involved in confrontational aggression, whereas girls are more likely to display truancy, substance abuse, or chronic lying. According to the DSM-5, some youth diagnosed with conduct disorder have limited prosocial emotions. They display minimal guilt or remorse and are constantly unconcerned about the feelings of others, their own wrongdoing, or poor performance at school or work. They are good at manipulating others and may appear superficially polite and friendly when they have something to gain. The DSM-5 diagnostic criteria include A, which is of course the repetitive and persistent pattern of behavior, in which the basic rights of others or major age-appropriate societal rules or norms are violated, and it is manifested by the presence of at least 3 of the following 15 criteria in the past 12 months from any of the following categories, with at least 1 criterion present in the past 6 months. One category is aggression toward people and animals, and you can see several examples listed here. The DSM-5 goes on to provide descriptors for the other categories that I've previously mentioned: destruction of property, deceitfulness or theft, and serious violations of rules. Continuing with the diagnostic criteria for conduct disorder, Criterion B, the disturbance in behavior causes clinically significant impairment in social, occupational, or academic functioning. And C, if the individual is 18 years or older, the criteria are not met for antisocial personality disorder. Youth with callous, unemotional traits are unconcerned about their victims' suffering or about possible punishment for their behavior. In fact, they show limited neural responsiveness in brain regions associated with empathy when they're presented with pictures of other people in pain, a reaction that differs significantly from that displayed by children without antisocial traits. In a study using magnetic resonance imaging, or MRI, adolescents with conduct disorder and callous traits demonstrated strong pleasure responses to video clips of people experiencing pain and distress. Not surprisingly, those with these traits are at high risk for continuing criminal behavior and receiving a diagnosis eventually of antisocial personality disorder in adulthood. The diagnostic codes for conduct disorder require specifiers. One is childhood onset type, where at least 1 symptom occurred prior to age 10. Adolescent onset type means no symptoms were present prior to age 10. And finally, unspecified onset. The criteria for diagnosis are met, but you don't have enough information to determine when the onset of symptoms occurred. Here's a little more clinical information about conduct disorder. The symptoms do vary with age and increase in severity as the person develops increased physical strength, cognitive strength, and sexual maturity. Symptoms emerge as less serious, such as lying and shoplifting, and then increase in severity. However, there are individual differences. More damaging behaviors at a younger age are predictive of a worse prognosis. And when individuals with conduct disorder reach adulthood, antisocial personality disorder may be considered. Antisocial personality disorder involves a pervasive pattern of disregard for and violation of the rights of others, occurring since the age of 15 years. Antisocial personality disorder cannot be diagnosed until the individual is at least 18 years of age. Both the DSM-5 and Alan Francis's text provide several differential diagnoses to consider and to rule out when considering a conduct disorder. I would just add and emphasize one: intermittent explosive disorder. Both conduct disorder and intermittent explosive disorder have high rates of aggression. However, with intermittent explosive disorder, the acts, the impulsive aggression, are not premeditated and do not have a specific objective.